We're going to move on to our last topic, which is biopharmaceutical lecture, and it's titled, Why Take a Risk? I'm not going to take a risk to disclose the content of this topic, so I'm going to leave it to the staff of BD Medical. Please welcome BD Medical.
So, good afternoon, everyone. Thank you for allowing me to be here today. My name is Nermeen Rushdi. I'm a clinical consultant with BD Medical. And today we're going to have a very, very short presentation on why take a risk. And I'm happy you were just saying that we don't want to take the risk, but before we move forward, what are the risks and how can we potentially help to avoid them? So when we talk about risks today, I know we've been talking about a lot of different things over the past few days. Today I'm going to talk about HAIs, hospital-acquired infections, and I hope that at least one of those four are of interest to everybody in the room. I know one of them definitely is, so ventilator-associated pneumonias, but unfortunately the focus for me today is going to be on bloodstream infections. So why are they a risk and why do I want to avoid them? If I look at the different causes of bloodstream infections, central line specifically, I'll find that the majority is caused by non-tunneled CVCs. I hope that everybody in the room agrees that they are a risk and that they are a concern, and that they are a concern that we can work together in collaboration to try and minimize them or even prevent them. So what is the impact of a bloodstream infection? How does it affect my hospital and my patients, my outcomes and my results? So on crude mortality, we have anywhere between 10 and 40%. With attributable mortality anywhere up to 15%, with prolongation of hospitalization up to 20%. And I've been working in this region for quite a while now, almost 15 years, and I've come to realize that in a lot of cases, you sometimes lack hospital beds when there's a patient who needs one, and I'm presuming this applies all over the world simply because I may have developed, or a patient who has acquired a hospital-acquired infection or a CLABSI and are now in the hospital simply because of that and not because of the original or initiative causative reaction, causative cause that they were in the hospital for in the first place. Attributable costs, I understand that in a lot of cases we don't really look at that figure per se, but if you go anywhere between $34,000 and $56,000 per central line associated bloodstream infection, that is a number that I think we can hopefully agree can be spent elsewhere to better our outcomes and our results and improve on our healthcare provision, improve on our patients' safety and quality of life. So preventability. About 15 years ago, there are two companies in the US called Medicaid and Medicare. They are insurance companies that provided hospitals with financial support, and their financial support poured into the hospitals where there were higher CLABSI rates per 1,000 days, higher urinary tract infections, higher VAPs, higher surgical site infections. About 10 years ago, or a little later, these hospitals realized that these infections, hospital-acquired infections, were no longer inevitable. They're not inevitable. They're not a must-have. They're actually quite preventable. But for us to be able to prevent them, we need to work together toward that and agree that irrespective of where we are today, there is always going to be room for improvement on whatever our outcomes and our results are now. So can we improve? I'm hoping everyone's saying yes, we can. So moving on, one of the methodologies that has been studied and evidence proven and gone back and forth on and confirmed by CDC, by JCI, by INS, by WHO, is that there are certain bundles that can be applied in our hospitals to standardize the kind of care we are giving our hospitals, our patients every single day. And when we standardize, we're better able to identify gaps and fill them and improve on them. So today we're going to be talking a little bit about the CLABSI bundles and how they can help us in our hospitals improve on the results that we have today. So one of the things I'd like to focus on is skin preparation. Before I insert my cannula, I'm going to use ultrasound or not, that's your choice or availability. I want to make sure that the area of insertion is 100% or as close to 100% clean and sterile. So I want to use a skin prep that will allow me to have a continual antimicrobial effect for up to 48 hours. I want to make sure that I use single-dose flushing solutions, but that I also actually do flush my lines to prevent or minimize clotting, blockage, as well as blood reflux into my cannula or my central line, which can very potentially be a cause for microbial growth. And last but not least, I want to try and prevent one of the two major concerns that I have in terms of risks, and that is needlestick injuries and blood exposure. And those can be prevented or minimized by the use of devices that will not allow me to even use a needle. So the needle is taken out and the blood exposure is prevented or minimized. So single-use devices, as well as needle-free connectors. So my objective is to prepare, maintain, and protect. How am I going to prepare? I'm going to prepare my skin before the insertion with the CDC recommended chlorhexidine. It appears to be a product that has been evidently proven to continue to give me antimicrobial effect for a 48-hour period. I'm then going to make sure that I maintain my line, and by maintaining my line, I mean I'm going to look after it, because the insertion of a central line is not an easy task, and one of the main purposes of my being there, inserting that line, is to make sure that that line will continue to function, will continue to perform for as long as it possibly can, without it having unfavorable outcomes. And last but not least is
2 minutes, please.
Okay, thank you. Last but not least is the protection part, which again, we talk about the chlorhexidine and the needle-free connectors, which will allow me access into my lines without having to use a needle, which will prevent or will protect both my patient and my nurse and my doctor from exposure that is 100% unnecessary. Now, having said all of that, it's also very important to mention that CDC, JCI strictly advise that irrespective of what the standardized procedures are, continuous education, monitoring, and training are very important for the success of any bundle that is put into place. And we are here today, as BD, committed to continue to be your trusted partner in healthcare, in the sense that we make this commitment, this promise today, we have made it in the past, and we continue to make it in the future. We're here to help with delivering to you all of the updates that are available to us, all of the new studies, all of the new guidelines that have been proven to actually move forward in terms of outcomes and results, so that your CLABSI rates drop, because 0 is a target that is achievable. It is achievable. It's been done before, and with all due respect, if it's been done by someone, then we can do it as well. It can be done. I know it hasn't seemed that way for a while, perhaps, but it can be done. And if we believe we can do it, you believe we can do it, we're here right next to you, working with you, alongside you, to make sure that does happen. So thank you very much for your attention. I appreciate it, and have a great day.
Okay, thank you.